topic for discussion is litigations in high-risk pregnancy. And I will be speaking only on the medico-legal aspect of high-risk pregnancy. A high-risk pregnancy is one in which a woman and a fetus face a higher than normal chance of experiencing problems. And it is a pregnancy which is complicated by a disease or disorder that may endanger the life or affect the health of the mother, the fetus, or the newborn. These risks may be due to the factors in the pregnancy itself, or they may stem from pre-existing maternal medical conditions. Obstetricians are most vulnerable to litigations because of 4 factors. Number 1, they have to balance 2 lives at the same time, the mother and the fetus. Then the story does not end with just the delivery of the baby, but continues for another minimum time period of another 6 weeks. Pregnancy and childbirth are perceived as physiological processes, and patients are relatively healthy and free from disease when they walk into the hospital. So any kind of an adverse consequence is not taken kindly by the relatives or the patient. The duties of an obstetrician are towards the mother and the unborn child to keep them safe, to provide information to the patient and the relatives regarding what kind of a treatment they are wanting to go ahead, what are the benefits, what is the purpose, the side effects, the complications, the long-term hazards, the percentage of success, and the adverse consequences of refusing a treatment in a language which is understandable to the patient. Alternative management options, whether you want to go ahead with a vaginal delivery or an instrumental delivery or even a cesarean section, needs to be discussed with the patient. In case you have done a full antenatal checkup for 9 months, it is imperative on your part to attend to the patient at the time of delivery. So in case you are not going to be present, you need to inform the patient beforehand and also give an alternative. Good history taking, proper examination, and relevant investigations are very, very important to foresee and anticipate the high-risk situations so that there is a hospital preparedness to deal with this kind of an emergency. An expectant mother with preeclampsia presented to the hospital with a past history of chronic hypertension and a premature birth. She landed up with a placental abruption, and because of this, an emergency C-section was done. The newborn baby developed cerebral palsy, seizures, hearing problems, and visual defects. So the boy's mother went ahead and sued the hospital staff for negligence and also claimed that they failed to appreciate her medical history, they did not properly monitor a preeclamptic patient, order laboratory tests, and even administer the hypertensive medication. This case was settled for $5.4 million. Foreseeability and anticipation of complications save many doctors from litigations, and errors in the antenatal screening and diagnosis can also lead to claims. The antenatal checkup is done more frequently than a normal person, and investigations regarding the blood and urine tests to check the health of the mother and the fetus, also to identify the genetic conditions and other health issues. Ultrasound is a gold standard to identify the problems with the development of the fetus, and these people with high-risk pregnancies normally require more frequent ultrasounds. Other tests, as and when required, may be suggested, for example, amniocentesis, CVS, fetal blood sampling, fetal echo, fetal MRI, and even genetic testing. When a baby is born with some kind of an abnormality, which could have been prevented, for example, spina bifida, meningomyelocele, trisomy 21, it becomes very important that if you have taken an adequate history. So history of valproic acid intake, or if you've not given folic acid in the first trimester of pregnancy and even 3 months in the prenatal period, if the patient has come to you for prenatal counseling, or you have, it does not occur to you that the patient is GDM or obese and can land up in problems, then this will be called as a wrongful birth and you can be litigated against. When the doctor fails to inform the possibilities of anomalies in the baby, for example, you have seen an HbA1c of 6.2. So now when the doctor fails to inform the possibilities of anomalies in the baby, I was speaking about HbA1c, that in case it is more than 6.2% and you expect some kind of a congenital anomaly in the baby, the relevant tests have not been done, and you have not even informed the patient, and you allow this child to be born, missing out on the chance that the patient may get an MTP done, then this will be called as a wrongful life, and again you can be litigated against. High-risk pregnancy will be suspected whenever there is a short stature of the patient, the pregnancy is of an elderly lady, of an obese person, whenever there is a previous recurrent miscarriage or preterm deliveries, severe anemia, multifetal gestation, placental abruption, threatened preterm labor, hemolytic anemia, thrombocytopenia or megaloblastic anemia, bleeding disorders, thalassemia, Rh incompatibility, antiphospholipid syndrome, neurological diseases, cancers in the mother, fibroid uterus. Whenever there is cervical incompetence, it can lead to preterm labor. Complicated abdominal surgery scars can lead to placental accreta spectrum. Smoker or alcoholic mother also land in a high-risk pregnancy. In case there is viral hepatitis during pregnancy or even an HIV infection in pregnancy, these are just to name a few. Medical disorders in pregnancy like complicated diabetes mellitus, pre-existing cardiac disease and its complications, thyroid disorders, preeclampsia, eclampsia, hemoglobinopathies, torch or chickenpox infection during pregnancy and autoimmune diseases can also lead to high-risk pregnancy. There was a case of a 33-year-old woman who went to her doctor at 13th week of pregnancy, and she had been exposed to her mother who was suffering with active shingles, and she went to get an immune globulin put. Now the doctor did not administer it, and 3 weeks later, she broke out in frank chickenpox. That was successfully treated. But at 19 and 24 weeks, the ultrasound stated that there was no abnormality. But when it was done at 32 weeks, the ultrasound showed IUGR and calcifications in the liver. And when amniocentesis was done, it showed the virus in the amniotic fluid. The child was delivered via C-section. The baby was born with severe neurological abnormalities, including an absent gag reflex, severe reflux, partial aplasia of one leg, and also required a 24/7 oxygen therapy. The mother sued her physicians for medical malpractice, and the patient said that in the prenatal period, she should have been vaccinated before her pregnancy and also administered the immune globulin after her exposure to chickenpox. So $3,325,000 was given as compensation. Another very famous case is Montgomery versus Lanarkshire Health Board, where Mrs. Montgomery was a short-statured woman who suffered from insulin-dependent diabetes mellitus. She had a macrosomic baby, but she was not informed of the chances of shoulder dystocia because the doctor's opinion conveyed that it was not such a serious problem. The serious problem was just minimal. And if she had explained it to the patient, she would have elected cesarean.
Hello. Hello.
So there was a difficult vaginal delivery. There was shoulder dystocia.
Please mute yourself.
So there was a difficult vaginal delivery, shoulder dystocia, and umbilical cord was partially or completely occluded, which led to hypoxia in the baby. And this led to the baby suffering from dyskinetic cerebral palsy. The OB-GYN had not disclosed the risk to her despite the patients asking if the size of the baby would be a potential problem. So the patient sued the doctor, saying that had she known about the complications, she would have opted for a cesarean section. The Supreme Court of UK gave the judgment in the patient's favor, and it also established a fact that the patient should be told whatever they want to know, not what the doctor thinks they should be told. The failure to diagnose and treat ectopic pregnancy is yet another place where you can be litigated against in case a serial serum beta HCG has not been done, or symptoms of lower abdominal pain, spotting, giddiness have been disregarded, and a first trimester ultrasound has not been done. There is a possibility of a preterm baby in high-risk pregnancies. And this is a point for litigation because the baby lands up usually with increased complications. They need the facility of a NICU And because of the extended stay in the neonatal ICU, there is a significant increase in the cost of treatment. So whenever there is a malnourished mother or a teenage pregnancy or a vitamin D deficiency, your antenna should go up that there is a risk of preterm baby and you should be prepared. Not advising retinal examination of the newborn to rule out retinopathy of prematurity is yet another place where you can be litigated against. So Maharaja Agrasen Hospital is a very, very famous landmark case where was bleeding torrentially. So an emergency cesarean was done. The child was critical, 1.49 kgs, and therefore the baby was referred over to Maharaja Agrasen Hospital for neonatal care. The standard operating protocol says that every premature infant needs to be tested for retinopathy of prematurity. But this child was brought to the hospital 4 times for a checkup, but the retinal examination was neither advised nor done. In December 2005, the mother noticed abnormal visual responses by the child and took the child to the Shroff Eye Center, where to her utmost dismay, the baby was diagnosed to be ROP stage 5, which means a total retinal detachment or complete blindness. The mother approached the gynecologist and also went over to Maharaja Agrasen Hospital for records, but this request was not heeded and the records were finally given to her after 6 months, and that too with the intervention of the Delhi Medical Council. There was no mention of eye checkups in any of the records, and the apex court directed compensation of 5 lakhs to be given to the child. So this gives us a message that in case standard guidelines have been laid down, then a doctor needs to have a very strong reason for not following them. Labor monitoring is very, very important in high-risk pregnancy, and a continuous tachography needs to be done and a partogram also needs to be maintained to save yourself in court. This was a case where the mother was admitted to the defendant hospital for delivery. The pregnancy was high risk due to IUGR and oligohydramnios, but the delivery team failed to continuously monitor the fetal heart. In CTG strips, which were studied later, signs of fetal distress were present, but they were not checked by the nurse. As soon as this was detected, the baby was delivered via emergency C-section. But by this time, the baby had already suffered oxygen deprivation during delivery and was born with permanent brain damage, developmental delays, and cognitive impairment. So a malpractice suit was filed, alleging that the hospital staff was negligent in failing to continuously monitor the baby, and number 2, failing to timely deliver her via a C-section. So $396,000 was given as settlement. High-risk pregnancy also leads to high-risk labor. There may be preterm labor. It may be complicated with a previous cesarean section. Then prolonged labor, obstructed labor, CPD and shoulder dystocia could lead to birth injuries. And retained placenta, inversion of uterus, rupture uterus, and perineal tears could lead to torrential bleeding at the time of delivery. The incidence of cesarean section usually goes up in high-risk pregnancy. And this is, and you can be litigated against because there may be a delayed decision or execution of cesarean section. There may be complications of cesarean section, like there may be a primary maternal mortality, fetal mortality. The patient can go in shock. There may be anesthetic complications. Then there may be trauma to the adjacent structures like the ureter, bladder, bowel. There may be PPH in case your incision has extended to the uterine arteries or there is atony of the uterus or DIC. And there may also be a uterine rupture. Birth injuries are very, very common. Brachial plexus injury, especially in shoulder dystocia. Cerebral palsy, wherever there has been hypoxia or fetal distress has not been detected in time. Spinal cord injuries, facial paralysis may be there. Bone fractures at the time when you're forcibly trying to pull the baby, there may be a fracture to the clavicle. And a perinatal asphyxia, which may lead to permanent brain damage. Vaginal birth after cesarean is also a form of a high-risk pregnancy and a high-risk delivery because it can lead to a number of complications. So you need to counsel the patient regarding the pros and cons and allow the patient to decide whether she would like to go ahead with a vaginal delivery or she would like a repeat cesarean section. A proper documented counseling is very, very important, and you will touch the patient only after taking a signed informed consent. In case you are trying for a repeat cesarean and the family still insists on a vaginal delivery, document it after writing and explaining the complications which could occur. In case they still refuse to sign the consent, refer them to another center. Imaging in obstetrics is a very, very important tool in detecting the high-risk pregnancy. So a first trimester scan by a trained and experienced ultrasonologist is very, very important. The ultrasound machine should be advanced and well maintained. In case the need for a second opinion arises, never hesitate to take it. A second trimester anomaly scan and a third trimester growth scan is also important. A fetal echo at 24 weeks should be advised wherever required. A 24-year-old woman of 29 weeks gestation visited a OB-GYN for an ultrasound, and the results indicated IUGR in the baby. The radiologist told the ultrasonologist to get serial ultrasounds done to confirm the diagnosis. But these instructions were never given to the woman, and she was sent home. She came back after a month with irregular fetal movements, and upon examination, there was fetal demise. The woman sued the OB-GYN and his practice for negligence, and also claimed that the doctor should have referred for further testing as per the radiologist's instructions. So $525,000 was given in settlement. This is IUFD is an obstetrician's nightmare. So you have to be prepared with the documents proving that it was not negligence, because the court is going to ask you that what was the reason for this demise, for this fetal demise? Could it be prevented? Did you do everything to prevent it? Did you follow the standard operating protocols? And did you manage the situation as any other prudent doctor would have done? This was a patient in her early 30s who was getting her antenatal checkup done in a hospital, and later on she shifted over to her parental home and started consultation over there. The umbilical cord was found around the neck of the baby on ultrasound scanning. 1 week later, she got admitted to the hospital. She was administered some drugs, and the relatives were very unhappy because the doctor had not come to see the patient throughout the night, and she was facing a lot of discomfort. In the morning at 7 a.m., the complainant was shifted over to the labor room, and another gynecologist was also called. There was the team members in the labor room had a serious discussion, and a total confusion was felt in their attitude. In the meantime, the fetal movements completely stopped. At 10:30 a.m., the doctor called up the husband of the complainant and said that the baby had passed meconium and they had to do an emergency surgery. After some time, after the surgery was done, the patient was stable, but the baby was not breathing well. So the baby was transferred to Lifeline Hospital in an ambulance accompanied by a doctor and a nurse who kept on resuscitating the baby on the way. And when they reached the hospital, the child was put on ventilation. After 1 hour, the relatives were informed that the child is no more. The complainant alleged that the discharge summary is a cooked one, and that patient was left attended by the doctor for 14 hours, which amounts to deficiency of service. The discharge summary stated that there was a J-shaped rent in the body of the uterus, which was not in the scanning report. Several contradictions were seen in the medical records, and the cord around the fetal neck was not written in the discharge. And a 10 lakh compensation was requested for. The defense said that after taking a consent, cervical ripening was done at 11 p.m., which resulted in mild contractions. The next day morning, a syntocinon drip was started, but it was seen that there was a fetal heart dip, so the syntocinon was stopped. By 10:15 a.m., the patient suddenly collapsed. FHR became irregular, and the patient's relatives were informed that the patient is being taken in for a cesarean section after getting a informed consent. There was spontaneous uterine rupture, which is a medically accepted known complication, and there was hematoma in the mesosalpinx. The OP also said that they had exercised due diligence. The child did not have any spontaneous respiratory activity. The child was tried to be resuscitated but failed, and hence was shifted over to another hospital having a neonatal ICU, but the baby could not be saved. So the judgment came that in case the doctor had diligently conducted cesarean at an earlier point of time, the rupture of uterus or the death of the baby could have been avoided, and compensation of 2 lakhs was awarded to the patient. There are a number of events in obstetrics where our forgetfulness also comes into play. For example, you have overlooked that the patient is adolescent or an elderly patient or an obese patient, because these people are more at risk to develop high-risk pregnancies. Or you forgot to give folic acid to the patient and the baby has been born with Down syndrome. You forgot to give aspirin after seeing a low PAPA and the mother lands up with preeclampsia or even a low birth weight baby. You forgot to give anti-D in Rh negative pregnancy, leading to reduced chances of developing rhesus antibodies and increased problems in the next pregnancy. You missed writing 12-week scan or getting a dual marker or a quad marker, and again the patient delivers an anomalous baby. There was a missed fetal growth retardation, or you missed out on significant and multiple fetal anomalies in the ultrasound. This was a case against 2 radiologists where at 20 weeks, Dr. Saluja gave a normal report and said that there were no abnormalities. At 32 weeks, oligohydramnios was reported by Dr. Soni and also said that the growth was normal. The fetal weight was only 1500 grams when it was reported to be 2500 grams, and the baby was not fully developed and left arm and kidney was missing. So the complainant went ahead and approached the court stating that it was negligence as the doctors had given wrong report on both these occasions. So he sued the doctor for medical incompetence and medical negligence. Dr. Saluja went ahead to defend himself, saying that the gynecologist had only asked for a growth scan. So he did not see the anomalies in the baby. And also that the baby was not in a position where the kidney and the other arm could be seen. But the court did not take this kindly, because the court said that in case you were unable to see that particular thing, you should have written that you have not been able to see. You should not have written that everything is normal. You could have asked for a rescan of that particular patient and also taken a second opinion in case it was required. So compensation of 15 lakhs was awarded to the patient. Now you have not taken any history of allergies to any drugs, food products or medication, and the patient has an anaphylactoid reaction to the medicine that you have given. OGTT was not done and GDM missed, leading to severe complications in the mother or the neonate and even an intrauterine fetal death. This was a case where a second gravida came to a gynecologist for antenatal checkup, and next day the doctor referred the patient to a specific imaging point for ultrasound, Messer's imaging point. Multiple ultrasounds were done, all reported normal. Elective cesarean section was performed, and again to the shock of the attendants and the patient, it was a grossly malformed male newborn. The newborn had agenesis of fingers, right leg below the knee and left foot below the ankle joint, which had not been diagnosed. There were problems with left eye closure, poor blink reflex, micrognathia, microglossia, and even left-sided facial palsy. So a compensation of 10 crores requested for. The court stated that the obstetrician was already aware that the patient was gestational diabetes mellitus. So the possibility of congenital malformations to the baby should have been informed to the patient, because the incidence in such patients is 7 to 10 times higher than normal patients. The ultrasonologist was not even aware of the fact that the patient was gestational diabetic status and hence did not do a targeted scan. Thus, it was a failure of the treating obstetrician not to advise a genetic sonogram or a 3D or a 4D sonography, as facilities were available in the centers in Nagpur. So the medical negligence was to the doctor imaging center, rupees 1.25 crores of complainant. Growth scan has not been advised, and the patient has had a IUGR and that has been missed. Not advising a targeted scan in high-risk pregnancy where you are expecting the complications, or not informing the ultrasonologist that the patient has Rh negative blood group or diabetes or even a cardiac disease. Serial Doppler ultrasounds have not been done despite the diagnosis of IUGR to time the delivery, resulting in an intrauterine death. Another event can be when there is edema of feet or body, which has been missed, leading to complications like preeclampsia. Or in case it is a unilateral edema of the foot, it can be blood clots, which can later lead to some kind of a pulmonary embolism. Patient complained of fever in the first trimester, but torch test was not advised, and the baby was born with anomalies. This was an appeal which was made by the patient because the state commission had stated that there was no negligence on the part of the doctor. So the patient went ahead to the National Commission, and the history was that the patient had fever in a 32 to 34 weeks of pregnancy. The torch test was not done. The baby was delivered at 36 weeks and had cerebral palsy with spastic tendencies, mental retardation, and 90% of permanent physical impairment. Expert opinion, which was taken from All India Institute, specially stated that the perinatal viral infection was the cause of this condition. And if due medical treatment had been given at birth, the disability would not have been so extensive, was what the complainant said, and asked for a 15 lakh compensation. The doctor said that there was already growth retardation of the baby at 34 to 35 weeks. The delivery was a precipitate one, took place within 1 hour. The umbilical cord was wound thrice around the baby's neck, and the baby had already passed meconium. There was difficulty in spontaneous initiation of breathing at birth, but the baby was resuscitated. So the judgment came that there was no negligence by the doctor. Torch test is not indicated in fevers between 32 to 34 weeks of pregnancy. But if this was present within 12 weeks, in the first 12 weeks, then this should have been done because fetal malformations can occur due to certain infections. Cerebral palsy cannot be diagnosed in the womb. Hence, the first appeal was dismissed with no order as to the costs. Another event which is seen in obstetrics is a blood pressure of 180-110 millimeter of mercury, urine protein 3+, and overlooked, leading to eclamptic fits. This was a case where a woman's blood pressure rose to dangerous levels after delivering twins. The nurses did not administer the prescribed drugs, and the woman went into cardiac arrest and suffered severe brain damage. 2 months later, she died from heart failure. The suit was filed, and when the documents were seen and the records were seen, there was no test which was done and no physician reference despite breathlessness and tachycardia. Her family was awarded $4 million in a lawsuit. Another scenario is when fetal distress not treated in time, resulting in birth asphyxia and adverse consequences like hypoxic ischemic encephalopathy or intrauterine fetal death. This was a very famous case of Sri Ashok Maruti Dundage versus Dr. Rashmi Sequeira, where the baby had convulsions and the complainant, the husband of the patient, filed this case and said that the gynecologist did not call a pediatrician despite request. The next day, there was a startle reflex in the baby, which was also neglected by the gynecologist. The doctor pleaded that the child was already IUGR. In case the child was subjected to labor, there is a higher incidence of morbidity and mortality, so they went ahead with the cesarean section. The baby was only 2.35 kg. Necessary intensive care was provided, and the baby's startle reflex was Moro's reflex, which is considered to be absolutely normal. The doctor also pleaded that asphyxia and brain damage is possible in IUGR babies, and these metabolic convulsions can occur anywhere in the world in the best of hands and does not imply deficiency in service. The child was being strictly monitored, and as soon as the nurse told her that there was a weak cry in the baby, she took steps to shift the patient over to Surya Nursing Home after informing the details of the baby to them. No pediatrician could be called because none of them were available at that time in an emergency. And low birth weight babies usually land up with complications, and there is always an inherent risk of complications. This is a pure miscarriage which is not actionable, and because of the excellent reasoning which was given by the doctor, the case was dismissed. Another scenario can be a fetal distress not diagnosed timely and action not taken because the OT was very busy or the doctor did not reach in time. Another event can be that a patient has complained to you of headache or upper epigastric pain, and you say that, okay, fine, just take a paracetamol. Or if low platelet count is overlooked, you've seen the CBC, you've seen the hemoglobin, but you did not notice a low platelet count. And the patient lands up in a HELP syndrome or an eclamptic fit. Anemia has been left untreated, leading to breathlessness, cardiac and renal problems. And also in severe anemia, blood transfusion has not been advised. Recently, there was a case where I was consulted in this case that a patient came at 38 weeks of pregnancy and to the hospital with severe breathlessness. And by the time she could be shifted into the triage, she had a cardiac arrest and passed away. Now, when her papers were checked, it was seen that she had a hemoglobin of 6.8 gram% throughout 9 months of her pregnancy, and blood transfusion had not been advised. So it is very, very imperative for all obstetricians to be aware that in case of severe anemia, blood transfusion should be advised. Now, in case wrong blood group has been transfused to the patient, this was a case of Mrs. Suman who went over to a government hospital for delivery, and as she required blood transfusion because there was severe anemia. The blood bank technician issued a B positive blood instead of A positive, and the patient developed complications. Her condition deteriorated. The fetus died, and the patient also suffered with kidney failure. So a complaint was filed before the commission. The doctors denied any negligence, and they said that it was even uncertain if the wrong blood transfusion caused the fetal death. And there were 3 patients with the same name who were admitted at that time, and hence this confusion. But the court stated that the first thing was that the lab technician issued the blood without cross-checking. Then the intern and house surgeon put the transfusion without checking the details of the patient with that on the blood bank. And because they were both under a senior doctor, so the senior doctor became vicariously liable. And because the nurse was also involved in the transfusion, so the hospital also became liable vicariously. And a 4 lakh compensation was given by the court. Another situation can be oligohydramnios has been overlooked and no action taken, resulting in an IUD. Or a polyhydramnios has been overlooked, resulting in birth of a baby with malformations. The patient complains of reduced fetal movements on Sunday. You tell the patient that you come next day for a checkup, and the patient comes to you with an IUFD. In this situation, the patient is not going to spare you. Full 9 months, and you have not even put the stent on the chest of the patient. So auscultation of the heart has been overlooked, resulting in catastrophic events during labor because the patient had a cardiac condition. Then during active management of 3rd stage of labor, you have administered methogen in patient of preeclampsia, PIH or RH negative, leading to complications. The patient has reported postpartum with breathlessness, but you have misdiagnosed it as asthma instead of pulmonary embolism or amniotic fluid embolism. I will cite a case regarding this particular issue a little later. Now, there was history of genetic diseases in the family. You have not got the relevant investigations because you never took the history. And another baby with genetic malformations has been born. You forgot to impress upon the HIV positive patient regarding significant risk transmitting HIV infection to the baby. And no precautions were taken, and the baby was HIV positive. So you have to counsel the patient with a lot of empathy. Improper counseling is when you start getting angry with the patient, you are not answering the patient's questions, or you're losing patience. So appropriate communication with the patient is vital in preventing litigations. And when you are counseling the patient, you have to have due knowledge of the nature of the problem you are anticipating. What is the percentage of its occurrence? What are the possibilities of complications and even the adverse consequences? So information provided to the patient should be factually correct and should be documented. Promising a favorable outcome increases the possibility of litigations and should be avoided. On the contrary, the patient should be made aware of all the possible complications which could occur. The patient may go ahead and ask you a number of questions. Am I at risk for preterm delivery? Will I need antepartum monitoring? Will it affect my delivery? And you need to have an answer to all these questions. The other point of litigation is whenever the patient is thoroughly dissatisfied with your treatment and is absolutely disgruntled. Like you forgot to screen for abnormalities, OGTT not done, you did not notice abnormal signs and symptoms, wrong, missed, or a delayed diagnosis, medical negligence, failed to diagnose the FGR. The abnormal results were there in the test reports, but you did not, you just happened to overlook it. And you forgot to screen for high-risk factors. So how does the doctor deal with his own forgetfulness? So you have to create an investigation protocol during pregnancy, counsel the patient regarding the same, hand it over to them after getting it signed, follow the standard operating protocols for the investigations, and also use a checklist to ensure that no high-risk factor is missed. Follow the SOPs in the antenatal management and the intrapartum management of high-risk pregnancy. Always book blood. Always get it cross-matched and arrange for every delivery patient, whether it be a vaginal delivery or a cesarean section, because failure to book blood can lead to a suboptimal fetal and maternal outcome, and this can lead to patient grievances. An Rh negative patient had a previous history of a cesarean with delivery of a dead baby. And in this present pregnancy, she was placenta previa grade 3. So she was advised a cesarean section, which she refused. 2 days later, she came back in an emergency with torrential bleeding, and emergency cesarean had to be performed without arranging blood. The baby was then adherent placenta. And once this was removed, the placental bed kept on bleeding and the patient went in shock. While shifting the patient over to a municipal hospital, the patient expired. A legal suit was filed stating that there was no preparation in the hospital to manage an emergency situation and blood had not been arranged. The post-mortem examination stated that there was intra-abdominal hemorrhage and 2.35 lakhs was awarded to the relatives of the patient because the notes of the gynecologist and the anesthetist did not concur. So here comes the importance of documentation. In yet another case, the patient was getting her antenatal checkups done in CGHS hospital, and she was informed that she could not have a normal delivery and had to undergo a cesarean section. A cesarean was done, a healthy male child delivered, and 20 minutes later, the husband was called in and asked to arrange for 2 units of blood because there was a sudden emergency. When he returned to the hospital, he was informed that the patient had landed up with some serious complication and was being shifted over to the Safdarjung hospital. Reaching that hospital, the patient had already expired. No post-mortem was suggested. So the allegations were that cesarean was neither necessary nor called for, hospital was ill-equipped to meet the emergency, and blood had not been arranged. and a compensation of 25 lakhs was asked for. The doctor said that the patient was elderly primary, Rh negative. ICTs had not been done. She had been advised the cesarean was performed for contracted pelvis. There was atonic PPH for which hysterectomy had to be done, and the patient was being transferred to Safdarjung Hospital when problem was seen. But the court stated that the documents did not give enough information about the sequence of events and the action taken by the team of doctors on the day of the mishap. Blood had not been arranged, and in case it was such a high-risk pregnancy, then she should have been operated in a hospital which was better equipped with the facility of a blood bank and a multidisciplinary team. Doctor and the hospital were both considered negligent, and a compensation of 5 lakhs was awarded. Always inform the patient in case the hospital is not equipped for ICU, NICU or ventilator, or it does not have a multidisciplinary team, and take signatures after counseling. Lack of consent is yet another issue for litigations, but I will not go into the details of consent because this is a full-fledged lecture in itself. When you claim to be a specialist, but you do not possess the requisite degree or qualification, is skills. Code of Ethics states that a physician shall not claim to be a specialist unless he has a special qualification in that branch. 11 lakhs compensation had to be paid by Dr. Vijay Suran of Jaipur for a fresh stillbirth. He was running a maternity home without being a qualified gynecologist. In yet another case, there was Vibha Sharma who was consulting a physician and was diagnosed as valvular disease of the heart. And she was told by Dr. Kailash Dubey to consult a cardiologist. Dr. Anand Goel, who claimed himself to be a cardiologist, diagnosed it as MS with MR and started the treatment. Vibha became pregnant. She started her antenatal checkups with Dr. Sharda Mathur, but continued her heart checkups with Dr. Goel. Her condition deteriorated, and then after 8 months, referred her over to a cardiologist who, on examination of the patient, advised an urgent hospitalization and to operation at the earliest. On that very same evening, the cesarean was performed, a baby delivered, but Vibha's condition deteriorated. She landed up in coma and she was declared dead the next morning. The court stated that Dr. Anand Goel was not qualified to treat heart diseases as he was not a cardiologist. And his prescription slip stated that he was a consultant physician and cardiologist, which was a misrepresentation. In other words, it is quackery, and that cannot be allowed. The gynae was also held responsible because after 8 months, she had referred the patient over to a cardiologist, which is not a standard of medical practice. She should have referred the patient earlier to a cardiologist. And the anesthetist was also considered negligent because she had gone ahead and preferred general anesthesia over a spinal or a spinal epidural anesthesia, because this would also produce good analgesia without major hemodynamic changes that a GA produces, as the patient was already in congestive cardiac failure. So penalty of 6,82,000 was imposed on the doctor. Get the antenatal investigations done according to the standard operating protocols to detect any high risk factors so that you can take a specialist opinion. All the high risk pregnancy should be detected while doing the antenatal care, whatever can be detected. Infrastructure equipped with adult ICU, NICU, blood arrangement, emergency drugs and fluids, lab for emergency investigations, and an OT should be there for emergency cesarean. Multi-speciality team should be there, defibrillator, ventilator, and a personnel also trained in resuscitation. Arrange blood for all the patients. It is not enough to communicate, but you should be able to prove it. So documentation of communication provides evidence of the same in court. This was a case where patient spontaneously aborted a cyanosed male baby of 650 grams at 24 to 25 weeks. The baby was resuscitated but ultimately died. The case was filed. The doctor stated that the patient had infection, oligohydramnios, and IUGR and had already been informed that the survival of the fetus or neonate after birth was bleak. No medical negligence was found against the doctor, but the nursing home was charged with the deficiency of service for not providing the attendance and non-availability of incubator and nursery. There is always a blame game where the patient is telling the doctor, we won't dream of blaming you. We leave that to the press. You got the investigations done, but you never had the time to check them. In placenta previa, you never informed me not to have intercourse. Or in GDM, you failed to communicate to me that sudden IUFD can occur with AUGR. You kept me in the dark regarding the risk to the baby. Or in AFE, DIC, sudden IUD, you said everything is fine. Then how did this occur? In a cesarean section, according to you, doctor, it was supposed to be a normal delivery. And in trauma to the abdominal structures, they say, do you actually know how to operate? So a procedure or a therapy performed but not documented is as good as not done. And the note should be legible and the notes of all the practitioners need to concur. The transfer to a higher or a tertiary center should be done according to the protocols. These protocols we've already discussed when we were discussing PPH, so I will not go into the details of this today. Hastily done transfer increases the mortality and morbidity and invites legal issues. And the important aspect during a transfer is the continuity of medical care. Any deficiency would be considered negligence by the court. In death of a patient can lead to medical, social, or legal implications. And this is one of the very, very major cases where cesarean was performed, a female baby delivered, and after the cesarean, the blood pressure shot up to 180, 110. The patient was advised to continue her tablet alpha-dopa and labetalol and discharged within 2 days without even stabilizing her blood pressure. Her condition worsened. She She was taken to Radha Krishna Hospital where she passed away on the same day. The consumer complaint was filed and 5.5 crores was asked as compensation. The post-mortem report stated that it was congestive cardiac failure, and the expert opinion also reported that there were several lapses in the treatment. The allegations were that severe preeclampsia had been misdiagnosed as a mild one. No investigations had been done. As per the ACOG guidelines, the patient should have been under observation for but the patient was discharged. Ma'am, just 2-3 more minutes. The OP was discharged, the patient was discharged after 50 hours, which amounts to negligence. And there was also a failure to diagnose pulmonary edema. So the defense said that the pregnancy was 38 plus 4 weeks. The termination was done via cesarean section. And in case it was severe preeclampsia, then the baby would have also suffered with IUGR. After delivery, the patient was kept under observation for 50 hours as per the guidelines of FOXI. The patient was also advised to consult the cardiac specialist, and the patient died after more than 14 hours of discharge, and hence it was due to the negligence of the patient herself. Cross-examination of the expert, Dr. Lipakshi, was not done. Therefore, the commission should not consider the said opinion. The court opined that there was a failure on 3 counts. Number 1, there was a failure to terminate the pregnancy should have been terminated at 37 weeks. The patient should have been kept under observation till 72 hours. And the doctor failed to diagnose the possibility of amniotic fluid embolism. And a compensation of 1 crore was awarded to the complainants. Failure to advise autopsy in cases of unexpected, suspicious, or unnatural deaths is also considered as deficiency of service, and the refusal by the relative should be documented. Every high-risk pregnancy is a potential threat, so always ensure documentation. Take adequate professional indemnity insurance. There should be no compromise on statutory requirements. Safeguard should be there with informed consent. A multi-speciality team should be there for delivering high-risk cases. Timely referrals and transfers need to be done according to the standard operating protocols. Auditing should be done in each and every hospital to prevent making the same mistake twice. The 3 R's, very, very important. Recognize, respond, and resolve. Risk management strategies, number 1, to save yourself from litigation. So you should have flow charts of all the high-risk pregnancies in your OT and labor room, and should also be for the benefit of the mother and child. So blah, 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 blah. This is the tale of a doctor. Either you do it in front of the patient or you do it in court. This is the situation of the doctor is like this toothbrush who says, sometimes I feel that I have the worst job in the world. But the tissue paper says, yeah, right. The patient is telling the doctor, Doc, I don't have just a second opinion. I have 143 Facebook friends saying that you are wrong. This is the today's scenario. Who should I examine first? You or your lawyer? New healthcare legislations are rolling in, and we need to keep abreast with all of them. This is the situation of a doctor in today's date, where Medicare rules are there, number of registrations are there. You need to document all of them. Cases are being filed, claims are being denied. So the doctor is angry, frustrated, and lost. Wishing you all a litigation-free practice, and thank you very much for a patient hearing.
Congratulate Dr. Arti for such a nice, very informative and comprehensive deliberation, very well explained with the cases and giving the message ki how to avoid the litigation in such high-risk pregnancy. Now I will
I'm really sorry for such long and a lengthy presentation.
No, it was very, but then very interesting. You made it very interesting also with the cases, and your slides were beautiful. So now one by one, I'll ask our chairpersons to comment and to share their experience.